Let's dive straight into this rapid-fire clinical drill on polytrauma and orthopedic emergencies. We're jumping right into the source material to tackle those high-yield scenarios you absolutely need to master.
Topic 1. Non-accidental injury red flags. Let's get into it.
Okay, here's our first clinical scenario. Which of the following presentations should immediately alert a clinician to suspect non-accidental injury in a patient? Take a look at the options.
If you guessed C, you hit the nail on the head. The crucial takeaway here is that hostile or uncooperative behavior from caretakers strongly suggests conflict or concealment. And honestly, that should override even the physical wounds you're seeing. Behavioral signs are literally just as critical as the clinical history. When you're evaluating vulnerable patients, remember these exam pearls. Inconsistent history, fractures in a preambulatory child, or posterior rib fractures, those are massive red flags. So the second you suspect non-accidental injury, your mandate shifts immediately. Your number one job is safeguarding that patient from further harm.
Section 2. Damage control orthopedics.
All right, let's look at the next scenario. Out of these 5 interventions, which one is explicitly not a part of damage control orthopedics? The answer is D, debridement. And why? Because damage control orthopedics prioritizes rapid, life-saving physiological stabilization over definitive anatomical wound care. Sure, debridement is absolutely essential later on for open wounds, but it's not part of that immediate life-over-limb phase. This perfectly illustrates the 5 main stages: resuscitation to correct the lethal triad, hemorrhage control, decompression of compartments, gross decontamination, and rapid fracture splintage using temporary external fixation. It's all about surviving the golden hour, right?
Next up, a 34-year-old patient presents with long bone fractures after polytrauma. Look closely at the clinical parameters here. Which one specifically mandates adapting damage control surgery rather than early total care? It's E, a body temperature of 33 degrees Celsius. This indicates severe hypothermia, which, as we know, is a key component of the physiological lethal triad. Hypothermia dropping below 34 degrees alongside metabolic acidosis and coagulopathy signals a profoundly unstable state. A patient presenting like this simply cannot tolerate the prolonged surgical stress and systemic inflammatory response of early total care. It's just too much for their system to handle. Check out how this breaks down the unstable parameters, things like acidosis and coagulopathy that mandate immediate damage control surgery. Look at those red lines: hypothermia under 34 degrees, a pH less than 7.2, serum lactate over 5. These are critical cutoffs compared to the stable green light criteria you'd want for early total care. This is literally your precise clinical roadmap for deciding when to intervene temporarily versus going in definitively.
Topic 3. Polytrauma surgical prioritization.
Okay, let's evaluate this complex scenario. A 40-year-old man is in a car crash. His BP is 80, he's got a supracondylar femur fracture, a subdural hematoma, and active intra-abdominal bleeding. Once that abdominal bleeding is controlled and the hematoma is drained in the OR, what's the proper treatment for the femur? The right answer is B, Steinman pin insertion and traction. Listen, definitive fixation causes further blood loss, and we have to rapidly bridge skeletal stabilization while protecting his vital physiology. The absolutely crucial point here is the core ATLS priority. What kills first must be managed first. Priority 1 is airway. 2 is circulation, like his abdominal hemorrhage. 3 is disability from the brain injury. And 4th is the orthopedic extremity injury. You secure that skeleton with traction to minimize soft tissue damage without compounding his shock. Shifting gears to topic 4, deceleration and blunt trauma. Here we go. A 45-year-old man driving 70 kilometers per hour hits a tree. Based on the options, which of these is most likely a classic deceleration injury? The answer is D, mesenteric avulsion. This perfectly demonstrates the physics of trauma. Mobile internal organs continue moving forward against fixed retroperitoneal attachments, creating massive shearing forces. When a vehicle stops abruptly, momentum keeps the body's internal contents in motion. It's like a violently sudden brake. The mobile loops of the small bowels shear away from the fixed dorsal mesentery. This can completely disrupt the vascular supply, devascularize entire segments of the bowel, and result in severe hemoperitoneum. Moving to a related mechanism, a 45-year-old male is in a road traffic accident, and he has a distinct seatbelt mark right across his abdomen. What is the most likely injured organ?
It's C, the duodenum. And that's because it lacks the mobility to slide away from the compression zone against the rigid vertebral column.
This is the absolute hallmark of the seatbelt complex. When a passenger is thrown forward against a lap belt, the intra-abdominal viscera are just crushed. The second and third parts of the duodenum are fixed and retroperitoneal, forcing them to absorb that full pressure right against the spine, leading to these covert bursting ruptures.
It's so crucial to contrast the obvious injuries, like chance fractures, with the highly lethal covert injuries, like hidden duodenal ruptures and mesenteric tears. You're going to easily spot that abdominal wall contusion, tracing the path of the lap belt for sure, but you have to actively investigate for the hidden damage. As you well know, the most dangerous injuries in blunt trauma are often the ones you literally can't see right away. Finally, topic 5, occult hemorrhage and nerves. Let's examine this anatomic scenario. Which of these specific nerve or vascular injuries is most commonly associated with a fracture to the neck of the fibula?
The correct answer is A, injury to the common perineal nerve. This leaves the patient unable to dorsiflex, leading to a permanent state known as foot drop. The nerve winds superficially right around the lateral neck of the fibula, and because it lies directly against the bone there, it's highly susceptible to compression, traction, or laceration during a fracture. That resulting motor deficit essentially paralyzes the anterior compartment muscles of the leg.
Okay, our final question. Which of these statements is clinically true regarding a closed femur fracture? Option A is correct, and that's because the thigh compartments are highly distensible. They can hide massive internal pooling. You see, the fascial compartments of the thigh are surrounded by dense quadriceps and hamstrings. A shaft fracture can lacerate the rich medullary blood supply or branches of the profunda femoris artery. Listen to this. Between 1.5 and 2 liters of blood can easily accumulate deep within those tissues, entirely masking a state of hemorrhagic shock happening right under your nose. So always keep this critical threshold of 2 liters of invisible blood loss in mind, and ask yourself, in the absolute chaos of massive trauma, did we also miss an occult femoral neck fracture? In any high-energy femoral shaft fracture, an ipsilateral femoral neck fracture is notoriously easy to miss on initial standard radiographs. There are distracting deformities, overlying traction splints, you name it, it's a lot to process. So the question is, are you looking closely enough at the hip joint to catch what's hidden?